Hello and welcome to our podcast Pager. I'm George Milner.
And I'm Stan Dale.
Tune in to hear us talk with some amazing people about the subjects changing medicine today. In this episode, we're joined by Dr. Caroline Elton to take a look at the issue of mental health amongst the medical profession. Dr. Elton is an occupational psychologist and author of the book Also Human, The Inner Lives of Doctors, which explores the causes and consequences of mental health challenges faced by clinicians. We look at why medicine is particularly demanding on mental health and what can be done about this, all the way from selection for medical school to peer support and specialised support services for doctors. In what areas has support crumbled away for junior doctors, and what are the challenges associated with bringing it back in a field in which ever-rising capabilities and patient expectations have not been met across the board with resources? So, Dr. Elton, thanks so much for joining me today.
Thank you. It's a pleasure.
So, as someone who has spent much of your career working in the field of mental health issues amongst doctors, could you just tell me a bit about the scale of the issue that's faced?
This is an area of which there's been a huge amount of research, but I think that there are three things which are clear. The first thing is that there is considerable distress in the medical profession. Figures obviously differ depending upon the population, the country, the measure, but if we're talking about depression, anxiety, a quarter to a third is a range that it often crops up. And then if we're thinking about in terms of occupational burnout, that's often the figures are higher. So that's the first thing, that there is a lot of distress. The second thing, which I think is very important, is that this is a global problem. And sometimes if I'm giving a talk, I might type burnout into PubMed and give it a 3 months timescale, the previous 3 months. And it's amazing how many papers there could be, 150 papers in the previous 3 months. And they are from really countries all over the world, including the developing world. So this is not a UK, US, Canada problem, an English-speaking world problem. This is a global problem. And then the third point is that whilst this isn't a new problem, and in my book I talk about, I give some figures of studies that began to be done in the UK in the 1980s. So in no way is this a new problem. And studies of physician suicide go back to the 50s and 60s. It's not a new problem, but I think there's some evidence that it's getting worse. Quite a large literature review carried out in 2018 by the Society of Occupational Medicine, and that was one of their conclusions, that things are getting worse. A bit gloomy, but I think we need to face up to that.
And I guess one of the important take-home points from this is actually that rates of mental health issues are widely reported to be higher amongst healthcare workers and doctors than lots of other specialties and lots of other professions around the world.
Yes, I mean, they're not the only healthcare workers, particularly frontline healthcare workers, are not the only professional groups, but teachers, for example, social workers also have high rates of burnout, and then emergency firefighters, all those sorts of groups as well. But it is a global problem. And I think that's important because we can rush into arguments, and these are important arguments, and they're a very significant part of what's going on about the underfunding and the workforce pressures with the NHS. And those are very real concerns that need to be addressed, definitely. But it's not just about the NHS.
Yeah, and certainly we'll touch upon later some of the potential causes of burnout from, as you said, funding to a whole number of other things. But first, I'd like to just quickly touch upon the idea of kind of stigma around mental health issues and the particular relevance that this might have to medicine.
Again, this is an issue that's been written about for the past, 30, 40 years, about the stigma of mental health within medicine. And I think there are a number of things going on. A bit of it is what I might call the bald barber or the fat dietitian. I think there's cultural assumptions that both the medical profession, but also the wider society, the society of people who are the patients of medical professionals, there's a sort of hope and belief that doctors shouldn't get ill, just as one might be, if you went to your car mechanic and their own car was bashed up and wasn't going, you might think, not sure I want to go to that person as the mechanic. I think there are these very understandable but ultimately irrational assumptions that your doctor shouldn't get ill. But I think that if we dig a bit deeper than that. At the bottom, that this is about the management of anxiety that inevitably arises from being a doctor. And there's somebody I quoted in the book who's a psychiatrist who wrote about his first day at med school. I remember my first day of med school as a young medical student with horror. We were casually introduced to our cadavers without any preparation or discussion. My first cut into the cadaver was the first of many traumatic experiences in medical school that changed me. I was being prepared psychologically to be an objective doctor. I now believe that this frightening experience was, with no preparation, began the unconscious psychological defensive split between the patient and me. Cadavers, our first patients, were made very distinct from us, the healthy, immortal medical students. Our defense against death, our specialness, was being established. So what my argument is that unless we give med students and practicing doctors better ways of managing the inevitable anxiety from their work, they are going to hang on to the message, and it's a message which gets institutionally reinforced, that doctors and patients belong to different species. Patients get ill, doctors don't. So doctors with any illness face stigma, and that I think is also an important. It's particularly acute when it comes to mental illness, but doctors with any illness face stigma, and doctors with mental illness face it most of all, because it's seen to fly in the face of rationality and control and other characteristics which the profession expects its members to have. And I have heard horror stories from the doctors who I've seen over the years from how they've been treated with physical health issues and most particularly with mental health issues. I've also heard wonderful stories as well. And that's important to stress. I can think of a student who really, a junior doctor who really stayed with me who I thought about for a long time. And when she first contacted me, she said, I have a diagnosis of unstable personality disorder. And my heart sank. I thought, oh, golly. And she had been fantastically supported in med school. And she was very, very bright. And actually, she had found a way with difficulty, she was a physician, with difficulty, she had got her MRCP. And with this doctor, what happened was that she was working, she'd stepped out of training and was in a staff grade, a non-training grade, in a very supportive department. But every so often people would come along and say, you're very, very bright. You should complete your training. You should move to another department. And actually that wasn't right for her. And her difficulty was that the system couldn't quite let her find a way that worked for her, which was to be part-time and not in training.
So on one hand, you've got some amazing experiences from people who've been well supported, but then also some worse experiences as well. And perhaps these are the experiences that people are worried about when they maybe have an emerging mental health disorder and they don't know exactly what's going to happen to them, and their fitness to practice could be put under spotlights. And this could really discourage people from actually coming forwards, especially if they don't feel that their performance is really slipping. This might be a barrier to stop it, to actually dealing with mental health issues early on.
I think that's absolutely right, that the stigma is a barrier to people being able, for the difficulty that a medical student or a junior doctor may feel compared to, let's say, a history graduate who's working as in the city might feel. I think it is different. But again, I think there are a number of points to make. The first of all is that there are specialist mental health services for doctors in the UK now. And the two services of which I am aware of and have had sort of different links with, they operate under the highest levels of confidentiality. and they operate under those very high levels of patient confidentiality, because if they don't, they know that doctors won't come to them and they can't do their work. They can't be of service. They can't provide a mental health service to the medical community. That, I think, is something that is important to stress. And the second thing is that in terms of, if we're talking about a referral to the GMC, fitness to practice issues, yes, there have been occasions, I think, where people have been dealt with less than sympathetically by either their trust or by the regulator or the deanery because of mental health issues. But actually, I've worked as I haven't done GMC fitness to practice, but I was a panel member for psychologist fitness to practice, and they operate under very similar sort of rules and legal framework. And what causes most concern is somebody who has what they would say has no insight into their mental health condition. And so that if one has been seen to seek help and to work with the clinician providing that mental health support, actually that's going to stand you in better stead of fitness to practice than if you don't seek help at all when you need it.
I guess this overall message that seeking help is better than not seeking help, even if actually seeking help might in the short term increase the chances that your fitness to practice is questioned, because no matter how confidential these kind of referral services are, ultimately I assume they still have the power to remove somebody's kind of rights to practice or to recommend it.
They will explain their approach to confidentiality right from the beginning. And yes, of course, if somebody is floridly psychotic and is completely unaware of that and unwilling to have any to seek, to go to occupational health or to their GP, or if they have a psychiatrist, also to go to their psychiatrist, and insisting on continuing working, yes. But certainly Claire Gerarda and her team at Practitioner Health Programme, and the Doc Health team, which is the other service, which is jointly run by the Royal Medical Benevolent Fund and the BMA. And Julia Bland is one of the senior clinicians there. They often talk about it's very, very rare because somebody has approached them. So in approaching them, there is some step towards getting treatment. These are self-referral services. Both of them are self-referral services. So, actually the numbers where they would but they would work, they have the experience. If somebody is working who they feel should not be working, they will have the experience. Maybe there's an addiction issue, whatever it is, alcoholism, they will have the experience to help that person contact occupational health and set in motion the process of treatment, of time from work treatment, and hopefully and usually recovery. So I think that there is the fear is understandable, but in reality, the issue in the UK of a doctor coming forward declaring a mental health issue and then their medical career being denied to them is not something that frequently happens. I think the situation is different in the States.
And I guess this brings up the importance of perhaps these organisations that deal with doctors' mental health being separate from their colleagues and the hospitals that they work in.
Absolutely. I mean, it's some of the horror stories have been, another student I can think of was on her psych rotation with her treating psychiatrist. I mean, that is those sorts of things should not happen.
And we touched upon it a little bit earlier, but I'd like to slightly unpick why, in particular, mental health issues are prevalent in medicine. And I guess the elephant in the corner here is funding and workload pressures, which we'll start with, but they don't necessarily fill the whole picture. So to what extent are they responsible for lots of the mental health issues around amongst doctors?
Medical work is hard work, and it's hard work psychologically, and I think one of the themes of my book that I was trying to open up a discussion about is that everybody acknowledges that medical work is hard work academically. Although actually I don't think the concepts that you will be dealing with as a medical student are probably as hard to get your head round as nuclear physics or or bits of philosophy. I think the hardness of medicine, a lot of it is about the volume of work, the stuff you have to get your head around, and the amount of memorization that is required. But you certainly need to be strong academically, and that's another thing that we can touch on. But there is, I think, a denial of the way in which it's hard psychologically, hard emotionally, that you will be, whether you're a medical student or a junior doctor, that you will be seeing and doing things. You'll be coming into contact with some of the really difficult things that happen in people. Children die. People have horrific burns. People get horrible diseases. They get cancer. They get motor neuron disease. Whatever it is, you have to come face to face with difficult stuff if you're a medical student and a junior doctor, and stuff which can, and again, I think that this isn't recognized, stuff which can affect you or your family, stuff which may already have affected you or your family. So I think that the intrinsic challenges, the intrinsic demands of the profession are under-recognized, under-theorized, under-thought about. But then, and there was a BMA survey last year which kind of looked at different factors, and they call those the endemic. I think I might call them, I'm not sure I like endemic, I might call them the inherent factors. But then there are all sorts of other things as well. They referred to systemic factors like understaffing, rota gaps, increased regulatory fears, and then stuff that goes on between people, interpersonal bullying, the erosion of peer support networks. I think that's a really important point that I end up talking about a lot, about the erosion of support networks. And then there are things like the environment, the lack of breaks. Maybe there's nowhere for you to sleep if you're on a night shift, all those sorts of things. And then there's the broader pressures from society of all increased patient expectation, and again, patients being more litigious. So these, I think, are some of the reasons. And then something which is very difficult to talk about, and one's not always very popular when one does, is the recognition, the kind of wounded healer element of this, that some people, and I think it's the minority, but there are some people who go into medicine as a way of treating others, as a way of dealing with their own psychological issues. So it is an incredibly demanding profession for everybody for all those reasons I've just listed. And then there is a subset who are particularly vulnerable.
It might not necessarily be just one thing that is making medicine stressful. It's a product of lots of different factors, some more inherent to medicine, as you mentioned, actually, the decisions with huge human consequences and emotional aspects of treating patients, but then also all these things that kind of affect people's working lives, whether it's the support networks around them or the amount of time that they have to work for. And would it be fair in saying that actually people can better deal with one of these things or two of these things on their own, but when they come together, that's when you often get the greatest issues?
I think as a general rule, that's right. And one of the things which I think is overlooked is this issue of supportive relationships at work. And it's something I end up talking about a lot, because there is a kind of another rhetoric going around, particularly with some older consultants the kind of the snowflake mantra, God, today's med students, they're such little petals. They melt at the smallest thing. And we had to work X zillion hours and it was so much tougher and da 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 da. And I think that is fundamentally a an unpsychological analysis of what's going on. From a psychological point of view, working as a doctor, you need to believe that you belong to the community of medics, that you are fit for purpose as an individual, and that there are people around who respect you and will support you and help you if, for whatever reason. There are so many ways in which the belief that you belong to this community and you're good enough to belong to this community have been eroded. So, for example, med schools are much bigger than they used to be. In London, certainly, they've all combined, apart from St George's. So the intake, you might be on a rotation as a med student and certainly in foundation, where you don't know anybody. That wouldn't have happened before when a med school. How big is your intake, George, at Cambridge each year?
It's about 250, I think, and then plus some graduates.
Okay, so that's small. That's very small.
And I still don't know everybody on the course.
So Manchester, some of those are 500 plus, but they would have been 80 or 100 probably a few years ago. Not a few years ago, but a previous generation. So med schools are much bigger. With foundation, people used to do their house officer jobs in the hospitals where they'd been at med school. But now they move all over the country. They used to have 6-month rotations. Now they're 4 months. Sometimes those 4 months are broken down into 2 months. So each time you've got to find your place in a new team, you've got to work out what you should be doing. You don't have, and it wasn't always benign, but when it worked well, there would have been a benign SHO who would be supporting the house officer and a more benign Reg who might be supporting the SHO, and those teams had a greater continuity. So all these, I think that this is part of the problem. And there was a recent study done by the GMC on some of these issues of the well-being of doctors, and they highlighted moving around too much as one of the issues.
And I guess within this, workload could be a double-edged sword. On one hand, actually increased workload could reduce the amount of time for actually having these really important personal relationships between doctors and allowing people to be supportive colleagues. But on the other hand, there's been this perhaps slight criticism as junior doctors' working hours have been reduced, that actually the camaraderie and the exposure that they get and the experience they get is also reduced with it, which could negatively affect their mental health and their experiences and their training.
Particularly in the craft specialties. I mean, if you think about it, it just doesn't make any sort of educational sense that when the European Working Time Directives kicked in and there were reductions on junior doctors' hours, somehow you were supposed to train the surgeon at the other end, but with many fewer hours. So I think that there are I wouldn't want to go back to doctors working the excessive hours they've worked in the past. We know that was bad for their mental health. We also know that it increased errors, and it increased things like crashing your car, driving back from a shift because you were totally exhausted. So it's not that I want to go back to those days, but I think that what happens is, and I often use this metaphor, that medical education is like a Rubik's Cube. They'll get things right on one facet, but they don't look at the impact of those shifts on the other facets. And certainly, I think that there need to be ways of building more community when you're shifting more often, and perhaps getting people to shift less. And sorry, but you were talking about the working hours, I think, as well, and perhaps we're seeing this now in the middle of the corona crisis, that there could be virtual ways of building teams who are not in the same physical locality. So I think people do need to be working less. I wouldn't want to go back to previous working hours, but I think that what has been lost in reducing the working hours needs to be thought about, and they need to be thinking about different solutions for bringing back some of the things that have been lost. I was really interested. I talked to a colleague who's a GP and head of GP training in her bit of London. And she was talking about how she's not physically seeing her colleagues because many of them are working from home they're not doing any patient contact. They're in the surgery, but not having any physical contact with those GPs who are having contact with patients who could be suffering. But that they have instituted an 11 o'clock huddle, which is either social distancing, depending on who's there and what they're doing, or dialing in remotely. And they'd never had time to do that before. But now they realise they have to. And she said it's having an extraordinary effect.
We've seen doctors lose social support outside hospitals. And do you think this could have counterintuitively a beneficial effect on relationships within hospitals, as you said, as people realise that the importance of the support networks there and colleagues and friends?
Yeah, I think I don't want to be sort of like Panglossian or Pollyanna and say, oh, it's all going to be marvellous. All the effects of this for the medical profession and the nursing profession are all going to be rosy. I think we can come back to some of the much more difficult things that could are happening and could remain in the aftermath of this, whenever that is. But I think that in those, and I'm not alone in thinking this, I think this is being written about in the BMJ and all sorts of by all sorts of academics who are psychiatrists and whatever, for whom this is their specialist area. I think that those students, medical students, because there are, as we talked about earlier, there are some medical students going in and helping as healthcare assistants, junior doctors, and also, of course, nurses as well, all the professionals, where they are well supported. I think that there can be a real growth in confidence, a growth in competence, and where they are well supported and sufficient attention is given to the team and promoting the well-being of that team, I think people will come out of it psychologically stronger. Yeah, absolutely. They'll think, well, I can deal with a pandemic. I've coped with a pandemic. Then, people aren't going to throw me anything much tougher than that. So I think that there is the potential for psychological growth, but it very much depends upon the psychological and social support that operates within the team.
So to unpick this further, what exactly could support entail then? We've kind of seen these structural support in maybe length of placements and resources, like just even places to kind of convene and have lunch at work. But on the level of a team and with your colleagues, what could support mean?
One of the papers, which is an excellent paper in the BMJ a couple of weeks ago by Professor Neil Greenberg, who's a professor of defence psychiatry, and so was active in the military and has looked at different ways of using some of the mechanisms that are used within the military, let's say after a particularly difficult incident, to support military personnel, and even before this has been involved in bringing them into, let's say, A&E teams or whatever. So he's written about things like preparation. Nobody should just be thrown onto this ward, whatever they're doing, with no preparation about what it might be like and what might be expected of them. They shouldn't be alone. They should be budded up with somebody else. There are all the things like you've talked about rest, about making sure that they have rest during the day, and at the end of the day, an opportunity at the end of the shift for people to get together, not for a full debriefing, because you may be aware that that's quite controversial, and that particularly after a critical incident, that a kind of a clumsy debriefing, there is some evidence that it can actually sort of set traumatic memories in stone and increase the risk of PTSD. But just the team coming together and reflecting about things that they've done well and things that they've done things that perhaps they could do differently the next day. And then there are things like that, if in the light of this pandemic, quite junior staff are taking on more responsibility. And one could see this, if medical students are now coming in as healthcare assistants, then, first and second year doctors, qualified doctors, may be having some role with those healthcare assistants, that those those who are shifting up in responsibility, their needs are not overlooked. All these sorts of things. Basically, management processes that should, in an ideal world, be happening all the time, but are not, but become critically important due to the current pressures. But I think that if these sorts of things are in place, one will see for some of the individuals involved in treating patients during the pandemic, one will see a growth in confidence and a sort of a strengthening of resilience. That can happen. There's the other side too.
And looking to medicine outside of a pandemic, why aren't these things happening already? We've touched a bit on actually kind of time pressures and how that can erode this, that actually these sorts of things might not be seen as the highest priority clinical tasks and might be therefore the first things to go. But are there any other reasons why actually these things haven't been done as well already as they perhaps should have been, given the huge benefits they have towards doctors' well-being and indeed patients' well-being as well?
I had an experience when I was researching the book, and I was looking at junior doctor suicide, and I found it deeply shocking to see how both in the UK and in the US, there were these articles that had been written 30, 40 years ago that were saying the same things, the same pressures that we're writing about now. And it made me very angry that things haven't changed. Why haven't they changed? I'm not a cultural historian, or a medical historian, so it's a difficult question for me to answer. But I think one part of this is that, in a way, medicine has become a victim of its own success. And this is across the world. There are so many incredible things that doctors, nurses can now do compared to, let's say, 50 years ago. And the focus has been on all these incredible developments without thinking about some of the psychological costs of the tremendous step forward. Part of it has been that the profession has taken the eye off the ball. They just haven't seen how all these extraordinary things that doctors can now do, and the complexity of practice have altered in so many different ways, the psychological demands of the work. Just to give you one tiny example, I think the expectations of patients are very different because they can read about all these extraordinary things that doctors can do. But of course, doctors can't save all patients all the time. But I think there's societal shifts where the expectations exceed the reality in an individual case. That puts huge pressure on those doctors. And then I think another issue about this is fears about cost. That if we were to provide a more psychologically robust environment for healthcare workers, it would just cost too much, so it just can't be done. And there's very good modelling. I'm very impressed by the work of a guy called Tate Shanafelt, who's an oncologist was at Mayo Clinic. He's now at Stanford Health. And he's really been a pioneer in looking at some of the systemic issues around burnout and also financial modelling, and showing that actually you get better patient outcomes, you get less complaints, you get less staff off sick, you get less staff moving around. And so this notion that if you were to provide a more psychologically attuned working environment, it would just be too expensive, that can be challenged.
And that's something that makes me slightly frustrated, that actually it seems like the only justification for improving doctors' mental health is framed around kind of economic consequences of them being fit as well, and the kind of impacts on patient safety. And it's not taken seemingly at all from a perspective of actually there is a responsibility to take care of staff at work, regardless of what the consequences of those things are. And actually, it doesn't seem particularly right that you only instigate change because it's having kind of knock-on effects. If you're burning people out in order to support a system, that's not very fair.
I totally agree, because I think that that we could think of this as a moral duty. There is a moral duty to look after those staff who are those people who are looking after other people, and it should be. It's a really important point, because one can argue and quibble about the financial bits. One can argue and quibble about, well, what are the effects on patient safety if the clinical workforce is more burnt out, and you can waste time and effort getting involved in those arguments, but the moral case is sort of irrefutable.
But yet, this isn't something that I guess doctors feel like they can challenge on their own, because at the end of the day, if you have a patient in front of you that needs treatment, no matter what time of the day it is, walking away and actually taking your breaks and things like that are suddenly not as important. And I think most doctors in those positions would be putting the health of their patients first because of the kind of the immediate reality of it. So it really seems like something that needs a solution from higher up in the food chain.
Yes, it is. It is a systemic. Predominantly, the causes of burnout are systemic, and that's why I think that medical students and junior doctors, they need to challenge the resilience rhetoric. This is all about building your resilience, and they need to have the evidence at their fingertips to challenge that and to say, this isn't about my resilience, that this is, and there are good data to show that this is not about I'm just a little snowflake and I'm going to melt when the pressure is up. This is about, these are organizational, these are systemic issues. So I really agree with you, and I think that I encourage students and junior doctors and more senior ones to challenge the way it can be framed, which of course is politically expedient, to be putting it back as an individual issue when it is not primarily about individuals.
You can see kind of an analogy with Matt Hancock blaming healthcare workers on using too much personal protective equipment right now.
I was thinking about exactly the same thing. It's appalling. It's appalling. I feel I couldn't agree with you more. And as you said, I'm my first year medical student son is now on a COVID ward somewhere. There will always be those political pressures. And the blame and the buck will be passed back to the individual. And I suppose one of my wishes in writing the book is to arm the individuals and teams as well to say, this isn't what it's about. And these are the data to show that this isn't what it's about. It's about the systems, and essentially the complexity of medical practice and the volume of stuff that doctors can do has just increased exponentially. And yet the funding for that and the understanding of the demands that this extraordinary work that doctors can do hasn't increased in line with that. And there's a gap. And that gap is the gap which is responsible for the distress that we see in the profession.
And it seems like actually this whole process is only going to get worse on its current trajectory. There was a really interesting article in the BMJ looking at what happens when doctors are subjected to burnout and suggesting that actually they manage to maintain kind of objective performance by actually shifting their capacity towards really kind of high priority clinical tasks at the expense of kind of simple things such as reassuring patients. And actually, you can almost see this happening in a healthcare system overall, which is using up its free capacity and compromising on some aspects of care at the priority of important things. But this is only a short-term solution, and it's not even necessarily a beneficial one. And actually, when demand increases again, suddenly I think there are going to be real questions asked about how we prioritize things now that everything is high priority.
I've often heard some of the clinicians working for the mental health services for doctors, like Practitioner Health Programme and Doc Health, talk about how work is the last thing to go, so that there can be doctors who are in considerable psychological distress and stuff going on in their private lives or their family lives can be really in meltdown, but they can still go and work adequately. But I think, I suspect I didn't see that article in the BMJ, but it makes intuitive sense to me that in terms of the prioritization, that certain things that even within a clinical day, so work is prioritized over non-work stuff. So non-work's in meltdown, but the doctor is still turning up for work. But then within the variety of different things that they have to do within the day, some things will be prioritized more than others, like you said, reassuring patients. But I might also see it as actually what they're trying to do is to minimize, if somebody is feeling very burnt out, it is to minimize their exposure to patient distress, because that it feels too overwhelming. So if you're going to go and reassure, have that patient doctor patient encounter, that's going to be emotionally demanding. And that feels too demanding, because one of the aspects of burnout is emotional exhaustion. So you don't do it.
It could be easy to interpret that as losing empathy.
Well, I think it probably is correct to think about it as a loss of empathy, because you are just overwhelmed, and when you are in that state of feeling overwhelmed, you haven't got it. It feels too much to go and hear more sorrow or confront more distress. So yes, it manifests itself as may manifest itself as a lack of empathy, but that is the product of the pressures that you've previously been under, rather than it being a moral judgment on the sort of person that you are. And it is a self-protective and necessary stance, actually, because you can't take any more. I think there's also the issue which you kind of raised in your earlier questions about whether signs are recognized fast enough. And from other clinical staff, if somebody looks as if a colleague is not in a good way psychologically, and I think I agree that I think signs aren't always recognized fast enough, but there's also the case that they can be recognized, but people don't know what to do. And there is a understandable reluctance. So if a clinician, let's say a consultant, sees a junior member of their team who seems to be struggling psychologically, they're in a difficult position because they don't want to occupy a dual role. They're not that colleague's doctor. They are a doctor, but they're not that colleague's doctor. They're that colleague, junior colleague's senior consultant on the team, but they're not that person's doctor. And I think that understandable and correct anxiety about dual roles actually stops people, more senior clinicians, having an initial conversation with somebody and pointing them in the direction of help.
And it comes down to the importance of being able to trust in the services that are available to help doctors, and know that, as well as an individual if you are going out seeking help, but as a colleague who is seeking help for their colleagues or recommending it, that you know that this is in their best interest and this organisation is supportive, and it's not synonymous with kind of signing a death warrant on their career.
On career, yeah, no, I agree. Well, I think, unfortunately, I mean, part of the jigsaw is the role of occupational health, and occupational health is patchy. That's polite. There's some excellent occupational health services around the country, excellent ones. And there have been other encounters that have been described to me with occupational health, which have been, to put it politely, suboptimal. And that is a real problem. So that if a senior is saying to a junior, you have to access occupational health, and occupational health doesn't really do a very good job, then that senior is in both are in a very difficult position. But I certainly think that fear of being seen to be a colleague or a junior doctor's clinician as opposed to their sort of line manager stops doctors having conversations with colleagues or with peers or with colleagues and encouraging them to access psychological help. And I would encourage people listening to this to go and look at the Practitioner Health Programme's website, to go and look at the BMA's pages on wellbeing, to go and look at Doc Health, because there are services out there and people don't always know about them. And one of the things that I've done, particularly since the publication of the book, because my role is to help people with their kind of work and career issues. And I have just done a huge amount of signposting to these different services and to people who didn't know they existed.
I guess you think that one barrier to people seeking help overall is there could be this underlying hope that actually the experiences that you're having and the symptoms that you're having are just going to resolve by themselves in the short term, and you just need to wait them out. And actually, it suddenly makes things far more serious if you seek out help for it.
Yeah, no, I think there can be a feeling that this, because they are, as medical students, you are often told how difficult and demanding it all is. I think there can be a feeling, well, it'll probably get better. I think sort of a partial answer is that as well. I've encountered many junior doctors, but often who have described how in medical school they've gone to talk to people. They're maybe their personal tutor and sort of said, I'm not sure this is right for me. And I think that often more senior clinicians to medical students or to junior doctors try to reassure. And when I run workshops, as I do, for senior clinicians on how to be better supervisors of students or junior doctors, I say, don't rush to reassure, listen. Just listen more and reassure less, because so often they're told, well, this is just a blip. This bit's very difficult. You'll feel better the next bit. And I've encountered doctors further down the line who've been told this on a regular basis. Oh, it's just this bit. It's the preclinical to clinical shift. Oh, you're coming up to finals. Oh, foundation year 1 is very difficult. Well, foundation year 2. And people need to listen more. Those involved with supporting students and doctors need to listen more and reassure less. Another thing that I always say is that clinically, about taking a history, and actually that when you're trying to help a doctor make some decisions about whether medicine is right for them or whether maybe they should be or they're in the wrong specialty or whatever, a lot of it is done on the current presenting symptoms, to use a medical analogy. Presenting complaint, and that there needs to be more of an understanding that those who are involved in supporting doctors and whatever their role, they need to take more of a history. And some people, when I've trained, have absolutely found that idea revolutionary and just so helpful, and others completely reject it. They just do not want to think about what I'm saying in terms of taking history. And I make it clear, I'm not talking about psychiatric history, but if you're talking to somebody about their work and about how they're feeling about their work, you've got to go and find out about why they became a doctor and, what's their trajectory been like through med school.
And it's hard when this is combined with an enormous investment in medical training. Almost, it seems like sometimes you want to brush under the carpet the idea that perhaps a lot of years spent going through this and a lot of commitment isn't necessarily going to come to a medical career.
I agree. I did some training at a medical school, quite senior medical school faculty in last year. And one of the things I was, and the dean was there in the group that I was training. And I said to them, I would love the dean on day one to say three things, whereas I think he definitely says one of these three things. He might say two, but he definitely doesn't say the third. And the first thing is, welcome, you've done really well to get here. Medicine is a fantastic career. There's so many different divergent opportunities, blah, blah, blah. Definitely they'll say that. The second one they probably say is, but it's a demanding career. At times you might have doubt whether it's right for you, and you might have a bit of a wobble, and there are people you can go and talk to without prejudice. They probably do say this, and they'll name the different support services. But the third thing they never say is, and there may be some people here for whom we will decide that medicine is not right for you. And we will always do our best to try to remediate the situation. And these are some of the different remedial and, help you if you failed an exam, blah, 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 blah. But ultimately, there will be some for whom, this is not going to work out for you. And I then met the dean at a different thing. I went to give a talk for GMC. And he said that he came up to me and he said he had given those 3 points. And then he said it went down like a lead balloon. It was incredibly unpopular. People were really angry. I don't know how he phrased them, but my argument is that, of course, there are going to be people there in that first year for whom medical career is not right. Because for there not to be, and I kind of touch on this in the book, selection would have to be 100%. Nobody wants to argue that's the case, and that's absurd. And B, people wouldn't change. Well, both of those are absurd. Selection is not 100%. And of course, people change during the course of those years and discover other interests and values and whatever. And yet it is seen to be a medical school problem if a failure, if not everybody in the year graduates, and some people either fail or they decide it's not for them. And yet there needs to be an acceptance that that's inevitable.
And what do you think of processes involved in selecting people for medical school, which is picking the people who are going to make good doctors?
In the book, I do name and shame, as it was then, 4 medical schools: yours, Cambridge, Oxford, Imperial and UCL. They use interview process, the standard interview model, when there are very good data to show it doesn't work. Because in medicine, unlike, let's say, a history degree, if people are selected into reading history at Cambridge, when they graduate, they're going to go and do all sorts of different jobs. So there isn't a metric that you can be using to look at interview scores and post-university performance. That's not the case with medicine, because the majority of people in med school are going to go on and become doctors. And so that you can be looking at whether you can look at foundation scores, you can look at the rates with which they've passed postgraduate exams. There are all sorts of later metrics which most of the medical school cohort will share, and that those studies have been done, and it has been shown that interviews are not predictors of later clinical performance. So why are those now? Imperial has learned the lesson. They are now using MMIs, multiple mini interviews, but bless them, and I talk as an Oxford graduate myself, Oxford, Cambridge and UCL, where I did my PhD, they are still using methods which have been shown not to work. It's extraordinary. And I often talk about that kind of eye of critical appraisal, which you are correctly trained to use in your medical training when you're looking at clinical data. You don't use when you're looking at medical education data.
And perhaps, actually, I'd offer maybe one counter question to this, which is, should we be selecting across the country on a one-size-fits-all criteria where there's a huge diversity of roles that doctors play and different fields which take different characteristics, different temperaments, different academic strengths? So could you see a system in which it's appropriate that although all doctors have got to go through the same hurdles early on in their careers, they can really branch out after that? Should we really be selecting on the same things for everybody?
No, I don't think you should. And in America, they have something called holistic review, which is, as it says on the tin, they're trying to look to assess a broader range of criteria of the applicants, and specific medical schools can add in criteria according to their particular the mission of the school. So you might have. I had a fascinating talk when I was researching the book with somebody who was involved with admissions to the University of New Mexico, where in that situation they want to have more Native American applicants who are serving those underserved communities that are living within that state, and you will have different criteria there. So I think that there needs to be a much more nuanced selection process. There needs to be some basic. You need to have, I definitely agree that part of the jigsaw is academic potential. It is an academically demanding course, but it's not. But one can probably test for that. A-levels are not always a good measure of that. I suspect that particularly UK CAT is, well, I know that actually is adding value, but that yes, I think it's an excellent idea to have a broader range of criteria. And I think what's encouraging is some of the new medical schools like Kenton Medway, which is starting this September. They are doing, again, wanting to the Medway towns. There's a lot of social deprivation, and wanting to attract applicants from within those communities with the potential, but who haven't necessarily got stunning A-level results.
I think I'm conscious of time. So if we were to bring this all together and we're looking forward into the future, what sorts of changes overall, if you could condense them, what sort of changes would you like to see within, well, let's say the medical education system and medicine as well, to improve doctors' mental health and well-being? This can be in a year, 5 years, 10 years.
At the end of my book, I end up with a sort of riff about understanding that the psychological well-being of clinical practitioners is as important as infection control. And I suppose that a more global answer is that I would like there to be the essential critical importance of giving adequate weight to emotional well-being rather than seeing it as a sort of nicety. But understanding it is as important as infection control. From selection of medical school right the way through to preparation for retirement, so for a whole career perspective, it's understood that the psychological well-being is essential. I think that I would also like there to be a shift, a much more nuanced understanding where the rhetoric shifts from this is the issues, the difficulties that an individual may face are about their own individual lack of resilience, to understanding that this is primarily a systemic issue, and that there are organizational and both within each healthcare organization and then more, of course, an aggregate within the NHS, where that these need to be given the attention they deserve. And in the States, there's this movement to have a chief wellness officer. This comes from the work that's been done in Stanford Medicine. And that is not a sort of middle-ranking, non-medical professional who runs, monthly courses or monthly classes on mindfulness or yoga. That is a board level appointment, and that there will be metrics that on retention, on staff well-being, on sickness absence, all those for whom that person on the board is responsible and has the budget to do so.
And that's, I think, a really important point, that having somebody whose job it is to do that and also has the power to kind of instigate changes maybe takes some insurmountable burden off one individual who has to juggle their practice and also trying to change a system from within.
It is happening in the US, and I was in Australia last year, and they had just doing some work, and they had appointed their first, in the hospital in Sydney, their first chief wellness officer. But I think that is the scale of the sorts of systemic shifts that need to be made if we're going to make a substantial difference.
I think I'd like to actually end on another little point from your book, which was this idea tied all together of that there's an inverse care law at play for doctors as well, in that around the country, you talked about it in terms of doctors in foundation placements, in terms of the people who are most in need of support and help are counterintuitively the people who are least likely to get it, because they are the ones who are often sent away to places with training programs that are less supportive. You mentioned everyone can see the rankings online and see people's reviews. People who need the help the most might not necessarily be getting it. And in this sense, I think doctors, can be seen as patients as well.
So the inverse care law was a GP, Julian Tudor Hart, who wrote about those patients with the greatest health needs often got the worst quality medical care. And I think I talk about it in the book in terms of foundation, but I think it happens again and again right the way throughout training in all sorts of different ways. And it would be great if those with the greatest needs got the most supportive educational and training placements. And sometimes when it does happen, often quite, just by chance, that somebody lands up in a particular placement where there's just fantastic support, and it is wonderful to see the difference that can be made. And I often say to people, if I see a client and they say they were told that they'd never make it as an ex-consultant, and they are making it as an ex-consultant in whatever their specialty is, I say you have an obligation to write back to that person in medical school or in foundation who told you you'd never make it. You have to tell them that you have made it, because otherwise, how will they learn? There's so much moving within the system that when somebody gets I'm thinking of one doctor in particular who's coming to the end of a very competitive specialty, who was very unhappy as a GP trainee and left GP just before she was about to complete. And everybody was up in arms, all her tutors. You're never going to succeed in this other specialty, which is very competitive. And why don't you at least finish your GP training? And she is going to make it in this. She's coming towards, she got a training place and she's coming towards the end of it. And I often say to her, on occasions when when you get your CCT, you have to write back to your GP tutor. Very politely, but otherwise, how are they going to stop saying you'll never make it as they're not, they don't know.
I remember seeing, I think, an example a couple of years ago was somebody bringing up their school reports, and it says something along the lines of so-and-so has kind of dreams of being a scientist. I think these are kind of mistaken. And he released this after winning the Nobel Prize.
And, you're in a powerful position when you've won the Nobel Prize. But you need feedback on the system, because otherwise what will stop those teachers or those tutors or whatever, they don't know. If they don't know, then they can carry on making those global and sometimes erroneous judgments, and without any knowledge of how wrong they were.
Yeah, and I guess it's all about making these evidence-based decisions overall, because I could also imagine a situation in which if you make this decision, say 100 times overall, you might be wrong about a couple of them, but actually the overall decision-making process is okay, because perhaps the price of some people not making it through to be a consultant when they otherwise could have is justified in the face of making a lot of other people think about their decisions carefully and actually not continuing with medical training that was destined to take up years of their life and damage their mental health and fail. And so I think there probably is I think no system will be perfect in this case, but it's about improving the system that we currently have.
And accepting that no system is perfect, and therefore some of the implications of the fact.
Being humble and acknowledging mistakes is the topic for another podcast, I think, on medicine. So I'm going to leave it there. So Dr. Elton, thanks so much for chatting with me.
My pleasure. Thank you for asking me.
Thank you for listening to the Pager podcast. If you've enjoyed it, then head to Spotify or iTunes to hear more.